I'm Anne Mullen. I'm a GP who works out of a health centre in Govan. I've been a GP for 25 years. I am a representative on the Scottish ACE Hub, and I also chair the Deep End GP group. Well, GPs are family practitioners, so we often deal with sometimes three generations of the same family who are our patients. And much of our work is done over quite long periods of time. So we do see vulnerable families, and we understand why they're vulnerable from a range of factors. So we're very well placed to support vulnerable families and children in our practice, whether that be with working with other colleagues or providing the continuity of care that they need from the GP, which is often to do with, can be to do with mental health issues or anxiety or whatever the factor is. And our role is really to provide that supportive role and also link in with the supportive network for those families. So early adversity in our patient groups is a very interesting question, because patients don't come in with labels on their head saying I've had an adverse childhood experience. It is up to us as caring professionals to understand what adversity in childhood looks like in either our child population or our adult population. And we can do that in a number of ways. Whether it's we understand the impact of being in care or having a mental health issue or an addiction issue. And our role is really to support that patient with their ongoing unmet needs. GPs have always understood how to work with vulnerable children and families. We know when patients are presenting in a state of distress. It could be that we have a new young adult registering with the practice who's just come out of care, or has managed to secure a flat after being homeless. Or we have a mum comes down who has a new baby and she has anxiety and issues of domestic abuse in the background. So we've always understood, I think, our role in providing support for that patient or their families indeed. The ACEs agenda just gives us another dimension to our vocabulary when we're speaking about it with patients that I think is very helpful. And also the ACEs work is now firmly rooted in neuroscience, which means that this is not just a soft topic for sociology or anthropology or historians to be interested in, or psychologists. There's actually a very, very strong, robust scientific evidence base for the impact of ACEs on brain development and emotional development. The language of ACEs is a new language that's coming into our language as practitioners. I think is really relevant. But actually our role is as pragmatic professionals. We are problem solvers. We don't work towards an ACEs tick box, but we do understand what the broad term of vulnerability means in families, and we do recognise it through behaviours and how patients present. And our role is to support vulnerable children and families and adults as they present, but the ACEs give us a more multifaceted understanding of the contributory factors to vulnerability, and I think that's a very helpful thing. One of the Deep End reports contains an account of a very vulnerable family, and it's written from the perspective of a very experienced GP who has all the three generations of that family as their patients. And we're talking about vulnerability in the grandmother who's got very poor health, multimorbidity, end of healthy life expectancy, which is very common in Deep End communities. And we're talking about there's some addictions in the family, some unaddressed mental health issues in the mum, who's a young mum who also has issues of her own, and the behaviour of the grandchild. So we're very well placed to understand what the intergenerational transfer of vulnerability looks like and how ACEs are relevant to that discussion. But I think what the point of that is it gives you a holistic framework to address these vulnerabilities in families. We're not there to judge and we're not there to police. We're there to support and to provide a sort of watchful waiting service to help families link in with many of the support services that are out there that perhaps they wouldn't take advantage of. The Deep End group, which has now been going for 10 years, represents the top most 100 deprived practices in Scotland. Our focus of learning now with the Deep End projects that we've been involved in, which includes the Government Ship and the Pioneer Project and the Embedded Welfare Rights Worker, is really to say that our message goes beyond just the top 100 most deprived practices. It's for all practices in Scotland that have deep end patients, which is all practices in Scotland. We have written many documents and many positional statements. We've reviewed a lot of the evidence, and we have responded to policy documents on that website. And you can see actually in our report 29 a description of the Government Ship project, all the work that we did with vulnerable families and children to improve outcomes, really join up fragmented services, advocate for the patient, and hopefully improve their outcomes in the long term. Throughout my career, I've always had an interest in vulnerability in children and families, and I've got a research interest in child neglect. And the child neglect research predates the ACE's work, and historians and anthropologists and psychologists have been writing about the effects of child neglect, which is an ACE, for many decades. So we know a lot about the impact of insecure attachment, for example, on brain development. The ACEs has allowed that to be reframed in a way that I think allows a more holistic discussion. Child neglect is quite a judgmental term. It's quite difficult to talk about with children and families directly. And so the ACEs framework allows us, I think, to get beyond that judgmental line, which is often associated with child protection measures and isn't really the point of working holistically with families. I think it's really important that we see this as a much more joined up way of working that allows professionals, third sector, statutory professionals to actually come together and discuss their common cause around vulnerable children and families and adults. We're all trying to work to improve outcomes for people who are vulnerable, to enable them to access services that are very useful and supportive to them. So I think if we have a common language and understanding, then we as professionals, when we're working with other agencies and our third sector partners, can actually work together to improve outcomes in a very practical way. We're trying to problem solve here, not actually make the problems worse for children and families because we're closing off services, or the services are not talking to each other, or the services are so fragmented that they can't actually work together. So it's about building links between the services, and that's extremely important to this agenda. I think a better question is to ask ourselves as professionals, as a society, why are we still having to have these conversations? Why does it seem so unique and groundbreaking to talk about this when in fact we know that professionals have been working in this field around trauma, vulnerability for many years. We're a state and society where child poverty rates are rising. Now, child poverty is not an ACE, but we know that impacts hugely in families. Financial vulnerability is absolutely linked to child well-being. So we know this, and we also know that lots of professionals are doing their bit as they see fit. They're working very holistically, working intuitively. They maybe don't have ACEs in the background in their head as knowledge, but they are trying to do their best to help children and families. So what are the barriers to actually making that happen? And we tried with our Government Ship project over 3 years to integrate all the services that we thought that would help us support not just our vulnerable children and families, as all the vulnerable patients that we had with their complex health and psychological issues. But one of our big work streams were vulnerable children and families. And we made a lot of progress in understanding what social work thresholds were, where social work saw their role in vulnerable children and families. We understood how mental health services could help. Third sector were incredibly important because there's a lot of third sector agencies do a lot of really good frontline work with children and families who would otherwise would be staggering towards a child protection threshold. So what are the barriers? And it's not because we don't want to work together, and it's not because we're not trying to do our best. There are a lot of structural reasons why professionals and third sector don't work together. Data protection is one, and we address that very much in our project. But actually, what's really the focus of all this and the bedrock of all this is trusted relationships and good communication between the professionals of third sector, statutory services, and also the patients themselves. You have to bring the patients into this conversation and help them understand that you're actually there, you're trying to coordinate things to help them, not to punish them, not to judge them. I think that's a really important message.